So my name is Dr. Kittikun Ngamudomkiat. Some study at the master degree of the Thammasat University. Today we got to talk about the topic of the efficacy of topical fluocinolone acetonide 0.1% in the combination with the fractional Erbium Yag laser for the treatment of the scalp psoriasis. My advisor is Ajahn Punya Pasadi Kanapati-kun and my co-advisor is Ajahn Warapon Veshapinan. The primary objective of this study to evaluate the efficacy of the topical 0.1% fluocinolone acetonide gel in the combination with the fractional Erbium Yag laser for the treatment of scalp psoriasis. And the secondary objective is to evaluate the efficient stabilization and the adverse effect of the combined treatment. And this is the protocol of my design study. We decide about the duration of the treatment for the 2 weeks at the baseline and start the treatment at the 2 weeks and follow up for the 1 week to look about the recurrent rate. And we split side of the lesion of the scalp psoriasis for the left and right side for the randomly and give the treatment for the FA with the laser and the FA compare. So the methodology summary. The patient have number 13 for the pilot study who have at least mild scalp psoriasis in Thammasat University and TTMH hospital. The randomized double blind for the fractional Erbium Yag laser one size and 0.1% FA once daily or lesion after the laser. Assessment for before and after procedure by the physician, measurement, PSSI score and patient satisfaction, PGA and visual scale. And observe for the safety, clinical observe, and screening lab test for the HBsAg suppression. The treatment duration that is 2 weeks, then follow up 1 week. And why we use 0.1% FA and why we use combined with the fractional Erbium Yag laser. Let me talk about the background of the scalp psoriasis first. At the background, the psoriasis is the chronic inflammatory skin disease characterized by the hyperproliferation and deflation of the keratinocytes change in the skin properties. They affecting 1 to 3% of the population in the general population in Thailand. It can affect any degree of part of the scalp psoriasis. The scalp is often in the initial size. Almost 80% of the patient with the psoriasis actually develop scalp psoriasis. And the scalp psoriasis have an impact for the quality of life, can cause intense itching, scale fall in the course. Scalp psoriasis is often difficult to treat.
We got a problem about the slide. It's still the same slide.
Oh, sorry. Not this slide. I want to share my slide. Sorry.
Okay, you can try again.
Okay, sorry. Could you please close the slide, please? Okay, sorry for a problem. Can you see my slide?
Yeah, it's good for now.
Okay, sorry.
Sorry for the mistake again.
Okay, and to go back for the background, and the scalp psoriasis is often difficult to treat due to anatomical area of the hair-bearing area. For the pathogenesis, our stress and the trauma of development environment that can induce the stress cell to produce about the interleukin cytokine, many cytokine to induce many cells such as the T cell and the inflammatory cell to explore the characteristics of the erythematous induration and inflammation of the scalp psoriasis. So the important factor is the T cell and inflammatory cytokine. And the topical steroid is the good treatment of choice because the property of the anti-inflammation that can dissolve the inflammatory cell and cytokine. And have about anti-proliferation property that can resolve the hyperproliferation of the stratum corneum, about the immunosuppressive that can resolve the T cell in the dermis, and they have the vasoconstriction property that can resolve about the psoriasis of the nitric oxide in the scalp psoriasis. But from the thickening of the stratum corneum, we usually use the high potency steroid. So the high potency steroid can cause about the irritation, skin atrophy, and HPA axis. That's why we use, currently we have many studies to use about a low or medium potency steroid for the treatment. They can reduce about the adverse effect from the high potency steroid use. And the focus in the FA, the fluocinolone acetonide or FA is the fluorinated steroid that have fluorine proof more than conventional treatments such as the TA in their structure at the C9 and C6 that have very strong affinity for the receptor in the lesion. The clinical presentation and evaluation of the scalp psoriasis, we use about the PSSI score instead of the for the PASI score. The PSSI score does focus on the erythema, induration, and discrimination only the scalp. And this is the recommendation of the definition of mild severe scalp psoriasis from the European Academy of Dermatology that we used in this study. For the FA or fluocinolone acetonide, they have the glucocorticoid receptor agonist that can bind the glucocorticoid receptor and have about the transcription lipoprotein to blocking the release of the acetic acid and preventing the synthesis of the inflammatory cytokine. And the basic structure of the FA is the fluorinated steroid that have the more fluorine group than TA at here at the circle of it. So this, we assume that the strong affinity for the nucleus in the lesion of FA that can make the FA strong enough and better than the conventional treatment. But when we look at this slide, the using topical steroid, corticosteroid at the currently, we have the only FA in the medium potency and low potency on the FA 0.01% and 0.025% FA. From previous study, this study used the fluocinolone acetonide topical oil for the scalp psoriasis, but they used the concentration in the 0.01% FA for the 3 weeks and stop the treatment. But when they stop the treatment, the recurrent rate is very high. So the 0.01% FA is good efficacy, but they have a high recurrent rate. And when we look at this study, the fluocinolone acetonide 0.1% cream have more efficacy than this FA 0.025% cream. Thus, this reason why increase the efficacy of the fluocinolone acetonide is necessary. So in my study, we conclude that we must use the increase of the consistency of the FA to 0.1% FA. And we use the study design for duration of the treatment for 2 weeks by referred by this study of the topical steroid that's shown in the previous study in the scalp psoriasis. They used about the 2 weeks of the randomized control trial. So we decide to the duration of the treatment for the 2 weeks and then stop to look at the recurrent rate of the 0.1% FA plus the laser and compare with 0.1% FA alone. And why we use the fractional Erbium Yag laser? So because the clinical application of the topical agent has been limited by barrier of the stratum corneum of the skin. The laser approach can damage the stratum corneum when used to enhance the dark penetration to epidermis and the dermis. And the Erbium Yag laser is associated with a faster healing time and fewer side effects compared to the CO2 laser because of its superficial absorption depth, decreased abrasion, and less residual thermal damage. And when we look at the topical duct delivery of the FA, the ideal transdermal duct is low molecular weight than 400 Dalton, but the molecular weight of FA is 452.495 Dalton, and the log P of the FA is 2.48. That is mean the FA is molecular weight is large and they have about the lipophilic. So the laser assistant, we assume that they can resolve this problem. And this is about the safety of this study because the normal thickness of the epidermis at the scalp is 33 to 37 micron, and the capillary reach to 0.2 min. Depth of the scalp of the skin surface. So the long remain that in the mist, we want to use this laser to introduce the duct to the skin, right? So the long remain duct in the dermis and to avoid systemic side effect. I think the depth, appropriate depth is 40 to 200 micron, and we decide to use the depth in this study to 50 micron. And this is inclusion criteria. The scalp psoriasis, we inclusion the scalp psoriasis who have the dry fatty scalp and well demarcated part with any supporting diagnosis such as the personal or family history scalp psoriasis, and about the orthos line, natural hairline involvement, and involvement of the frontal hairline, and the present characteristic nail change or ospit sign. And age 18 or above of the with the clinical diagnosis of the chronic plaque scalp psoriasis, and the duration more than 6 months, at least the mild scalp psoriasis define the PSSI score more than 6, and the earliest involvement more than 10%. And if exercise patient with any topical treatment on the scalp psoriasis in the past 2 weeks and oral systemic medication for the psoriasis 3 months prior to the study, patient with the presence of the seborrheic dermatitis or other inflammatory skin disease will exclude, and the pregnant and lactating women too. About the material and method, the topical corticosteroid or other used from the previous study, we decided to use the topical 0.1% FA 1 to 4 grams per day in the morning for individual patient, depending on the area size. And every patient are taking non-medical shampoo once daily at the bedtime. And instrument of the parameter laser, we use 2,940 Erbium Yag laser parameter were as follows. And the energy depth is 50 micron. And this is the result. The result of treatment, as you can see in the 3 weeks, the combined treatment and compared with the FA, they have about a significant of the decrease in the erythema, induration, and desquamation. This is another patient. We use the treatment for the 2 weeks and follow up for the 1 week at the week 3. And this is the result of the erythema, induration, and desquamation. As you can see on the baseline, the erythema, induration, and desquamation that have about a significant decrease in the baseline compared with the week 3 and baseline. But the mean p value is not significant when we compare both groups. As you can see in this graph, the mean SD of the score of each visit compared between the accumulation 0.1% FA with the laser and VS FA alone. As you can see in this graph, the baseline of the PSSI in the erythema, induration, and discrimination that can decrease in the both group, but the difference between the both group is not significant. About the area involvement too, the area involvement in the both the group, they have this significant decrease when we combine the baseline and the week 3, but when we combine together, it's not significant studies. At the improvement of the PSI score, at the baseline in the laser plus the FA, the baseline PSI is 23, and in the visit 3, the PSI is remain 10. Compared with the DAT alone, with the FA alone, the PSI is 23 too, and in the week 3, the PSI remain 11. About the patient assessment, the patient assessment, they have the both in the work group is in a good way. In the patient assessment, the GA score in the both group at the 3, average 3 to decrease in the baseline to invasivity at the 1 score is remain 1. And this is the visual scale to evaluate about the patient satisfaction is decreased too. About the side effect, pain score and irritation score, they have minimal of the pain score when we use the laser in the 0.85 and average baseline and 0.69 at the base one, at the visit 1. And irritation score is minimal too. About the morning serum cortisol, we use this we use the volunteer for the patient to inform the 13. We can get about the 3% to get the morning corticosteroid lab test at the visit and at first visit and visit 3. And they have to know about the psoriasis patient when we use the FA in the scalp psoriasis. For the discussion, both therapy of the 0.1% FA plus the laser and 0.1% FA alone shown decreasing the erythema, induration, and discrimination when we compare to the baseline with the statistical significance. This may due to the topical FA is topical steroid that can be standard treatment of scalp psoriasis. And the erythema, induration, and the discrimination, according to the result, erythema, induration, and discrimination in the combination group was slightly better than that alone at the week 3. This can indicate that the term of the dermatology opinion fractional Erbium Yag laser can use to be a laser assistant transdermal by the laser penetration lead to epidermis and dermis, and to transmit the topical corticosteroid may handle the slightly resurfacing at the thickening part of the scalp psoriasis. But the study was not no statistical significant difference between two groups. And the PSSI shown the statistical significant improvement in the every visiting comparing to the baseline in the both group in the topical FA and laser and the FA, as you can see in this slide. So the results shown that both treatment groups were effective treatment for the scalp psoriasis. They can reducing about the symptom of the scalp psoriasis compared to the baseline. However, it does not show the significance between the both groups. This is made due to good affinity and penetration of the fluocinolone acetonide alone in the both group. It did no significantly significant difference between them. However, in this study, we used the energy depth fractional Erbium Yag laser for 50 micron to penetrate the stratum corneum. So when the epidermis and the minimal part of the upper dermis on the lesion, while treatment area in this study on scalp, and the follicular penetration allow a lipid of the direct transport into the folliculum region where penetration by into the living tissue is penetration by the reduced barrier property. A greater difference PSSI may show. This is my recommendation. A greater difference in PSSI may show if the study can change the energy laser and change the location of the psoriasis lesion, has the larger group of the patient or have the larger group of the patient or the longer of study period. And they have no side effect, significant side effect, such as the skin atrophy, oxalate ataxia, or HPAS suppression in all study in all patients. So the conclusion, this randomized split of the lesion, the Bavai study demonstrated that both of the treatment are effective and safe treatment option for patient with scalp psoriasis, where statistically significant decrease in the eczema, invasion, and discoloration without a serious adverse effect after the treatment. This study showed that both of the treatment can reduce the symptom of the scalp psoriasis in 2 weeks. Moreover, there were low recurrence rate after the stop treatment for the 1 week. However, combination in treatment 0.1% FA with the laser showing minimal less mean duration and discrimination score than 0.1% alone, but no statistically significant difference between two groups. The recommendation, the limitation of this study are small of the subject and limitation of the period time. The further study with more subject and longer duration of follow-up should be performed and should study in the other parameter of the fractional Erbium Yag laser and another recommendation for the psoriasis lesion to evaluate those possible hypotheses. Thank you for your attention.
Okay, thank you. So because of time limitation, maybe just one question from the audience.
Okay. Thank
Yes.
you.
Question?
Can I ask question? Okay.
Yes, please.
Yes. To my understanding, I think psoriasis lesion do you have variation in the thickness of the lesion, right? Because my question is, the size of the lesion play any roles for the penetration of the laser? You understand my question?
Pardon? You mean about
the size of the lesions?
Okay.
In my understanding, I think the size will play some different effect. Because the laser will penetrate through the thickness of the lesion, right? If the
Yes.
thickness is great, the penetration will be less effective. It means that the penetration of the drug into the lesion will be less, to my understanding. Yeah. Do you think that?
Okay.
Okay.
Okay. So this is the limitation of my protocol too, because we can use only one parameter for the depth of the laser, and we use about the safety and effective depth for the laser to penetrate the stratum corneum and introduce the dye to the skin at the 50 micron. I and my advisor think about it too, because the 50 micron sometimes in the normal thickness of the scalp is 30, but in the psoriasis lesion, we don't know the thickness, the truly thickness of the lesion. So when we can assume in the safety of the depth and assume for the normal thickness from the scalp depth only. This is the limitation of my protocol.
Yes, I think that maybe explain why the results is not successful.
Yes, maybe that is the reason. But the FA is good, very good affinity, and I have another research for treatment compare between fluocinolone, acetonide, and TA, and the FA is better than the TA too. So it can mean it can consume that the FA is the good affinity to use alone, and that have a better effect than the conventional treatment.
Thank you very much.
Thank you very much.